specifically decoding general stomach discomfort known as dyspepsia and ulcers. Dyspepsia sounds like a very common, often vague term.
It is. It's sort of a catch-all. Dyspepsia covers a range of symptoms in the upper abdomen discomfort, maybe feeling full right after eating or getting full too quickly, early satiety.
So what's the first step?
Well, the initial practical approach is often to try and eliminate aggravating factors like NSAIDs, ibuprofen, naproxen, and excessive alcohol. See if that helps.
Here's where it gets really interesting and practical for you, our listener. The age-based evaluation for stomach issues. This seems key.
It really is. If you're under 60 and experiencing new dyspepsia symptoms without clear GERD symptoms, you should first be tested for Helicobacter pylori infection.
The H. pylori bug.
Exactly. Usually with a non-invasive test like a urea breath test or a stool antigen test.
Okay, and if that's negative?
Then a trial of a PPI, like we discussed for GERD, is appropriate. However, and this is a key takeaway, if you're 60 or older with new onset dyspepsia.
The approach changes.
Completely. An upper endoscopy is the recommended initial evaluation. The age threshold really shifts the diagnostic pathway because the risk of something more serious, like cancer, increases with age.
And just like with the esophagus, there are clear alarm features for dyspepsia that absolutely require an endoscopy, regardless of age, right?
Absolutely. These include being over 50 with uninvestigated dyspepsia, meaning it hasn't been checked out before anemia, any difficulty or pain with swallowing, dysphagia or odynophagia, vomiting, unexplained weight loss.
Family history.
Yes, a family history of upper GI cancer, or a personal history of certain stomach conditions like peptic ulcer disease, previous gastric surgery, or finding an abdominal mass on examination. These are your body's urgent signals saying, look closer.
So if H. pylori is suspected, how is it diagnosed for sure and then treated?
Diagnosis is either non-invasive with those urea breath or fecal antigen tests we mentioned, or through a biopsy taken during an endoscopy if one is being done anyway.
Okay.
And it's important to note, PPIs can make those non-invasive tests less accurate. They can decrease the sensitivity. So ideally, PPIs should be held for about 2 weeks before testing to get a reliable result.
That's a vital practical detail. And for treatment, what's the standard approach?
Standard triple therapy, that's a PPI plus 2 antibiotics, usually clarithromycin and amoxicillin, for 10-14 days is first line, assuming no penicillin allergy or prior use of that type of antibiotic, a macrolide.
And if that doesn't work, or there's resistance?
If there's high resistance to those antibiotics in the community, or if the initial treatment fails, we move to quadruple therapy, a PPI plus bismuth, like in Pepto-Bismol, and 2 different antibiotics, metronidazole and tetracycline, also for 10 to 14 days.
And checking it's gone is important.
Crucial. Eradication of the bacteria should always be confirmed after treatment because it's so important to get rid of it completely.
H. pylori isn't just about ulcers or discomfort. This is a significant aha moment.
Yeah.
There's a strong, quite sinister link to certain stomach cancers and a type of lymphoma called multimphoma.
Yes, that's right.
Especially in patients from regions where H. pylori is very common, like East Asia or Latin America.
Exactly. This makes biopsies during endoscopy and potentially even repeat endoscopy really important in those cases, almost as a cancer prevention strategy. Catching changes early.
This raises another important point. What about NSAID-related gastrointestinal injury? So many people take over-the-counter pain relievers.
It's incredibly common. For prevention, if you're at high or moderate risk for GI problems and you need to take chronic NSAIDs, things like ibuprofen or naproxen regularly,
What should you do?
the recommendation is often to switch to a different type, a selective KOX2 inhibitor like celecoxib, if appropriate, or to add a daily PPI for protection.
And what about coated aspirin? Does that help the stomach?
Our sources clarify a surprising fact here. Enteric coating on aspirin, designed to protect the stomach, does not actually reduce the risk of this type of GI injury or bleeding, despite what many people think.
That's good to know. So if the damage is already done.
For managing NSAI-induced injury, PPIs are the preferred agent for both treatment and prevention of recurrence. And interestingly, the combination of celecoxib plus a twice-daily PPI has been shown to significantly reduce recurrent ulcer bleeding in those at high risk.
Finally, in our stomach section, let's touch on gastroparesis. It sounds like the stomach is just slow. What are the key symptoms and how is it diagnosed?
Yeah, slow stomach is a good way to think about it. Patients often experience nausea, sometimes vomiting, early satiety, meaning they feel full after only a few bites bloating, abdominal pain, and sometimes weight loss because they just can't eat enough.
How do you confirm it's gastroparesis?
First, doctors need to rule out any physical blockages or mucosal problems with an upper endoscopy. Make sure nothing's actually obstructing the exit.
Makes sense.
Then, gastric emptying scintigraphy is the key test. This involves eating a meal tagged with a tiny bit of radioactive material and using a scanner to actually measure how fast food moves out of your stomach. It proves there's a delay.
What are the common culprits behind gastroparesis? Why does the stomach slow down?
Common causes include long-standing diabetes, often due to nerve damage, what's called autonomic neuropathy. Certain medications can also do it, like opioids or anticholinergic drugs, or sometimes it happens after surgery due to injury to the vagus nerve, which helps control stomach emptying.
And how is it managed? Is there a quick fix?
Unfortunately, no, it's often about management rather than cure. Dietary changes are key. Frequent, small, low-fat meals with soluble fiber seem to work best. Promotility drugs like metoclopramide can help speed things up.
But side effects?
Yes, metoclopramide is the only FDA-approved drug specifically for this, but it carries a risk of side effects like tardive dyskinesia, which involves involuntary movements. Erythromycin, an antibiotic, can also be used short-term sometimes for its promotility effect. It's often challenging.
All right, let's move into the mid and lower GI, starting with the pancreas. This organ kind of nestled behind your stomach. It often feels a bit temperamental. And when something goes wrong, it can be quite serious and incredibly painful.
It certainly can be. The acute pancreatitis is a prime example of that. What's fascinating, or maybe sobering, is that the vast majority, maybe 80% of cases, are caused by just two main things: gallstones getting stuck and excessive alcohol use.
Just two things causing most cases.
Wow.
So how is it diagnosed? What are the key indicators when someone comes in with that severe pain?
You typically need 2 out of 3 criteria. First, that acute onset of severe upper abdominal pain, often radiating to the back. Second, a sharp elevation in specific blood enzymes, lipase, or amylase, usually at least 3 times the upper limit of normal.
Okay.
And third, characteristic findings on imaging, like CT or ultrasound. A transabdominal ultrasound is usually the first imaging step to look for gallstones, since they're such a common trigger.
And what's the management approach for such an acute and painful condition? It sounds like people are really sick.
They are often very sick. Supportive care is paramount, lots of IV fluids, good pain management. For gallstone pancreatitis, if there's evidence of a blockage in the main bile duct or an infection of the bile ducts, cholangitis.
Then what?
Then early endoscopic retrograde cholangiopancreatography, or ERCP, is indicated to remove the stone or relieve the blockage.
Oh.
And here's a key preventative step. Once the patient recovers from the acute episode, the gallbladder should usually be removed, a cholecystectomy, to prevent it from happening again.
What about complications like infection?
If infected pancreatic tissue, necrotizing pancreatitis, is suspected, antibiotics are used, often potent ones like carbapenems, sometimes guided by a CT scan with a needle aspiration to confirm infection. And importantly, feeding the gut directly with enteral nutrition, like through a feeding tube, is generally preferred over IV nutrition, parenteral nutrition.
That's a lot for acute. What about chronic pancreatitis, the long-haul version?
Right. The hallmark symptom there is chronic, often debilitating abdominal pain, frequently radiating straight through to the back. And historically, chronic alcohol abuse is the most common cause, although other factors like genetics and smoking are increasingly recognized.
So how do you manage that ongoing pain and the other symptoms that come with a long-term condition like this? It must be tough.
It is very tough. Counseling to stop smoking and drinking alcohol is absolutely essential, as these continue to damage the pancreas. For pain, simpler analgesics like acetaminophen or ibuprofen, maybe tramadol, are first line. Sometimes medications that target nerve pain, like pregabalin or low-dose tricyclic antidepressants, can be helpful adjuncts.
And digestion problems.
Yes, because the pancreas isn't making enough digestive enzymes, patients often get steatorrhea that's fatty, oily, difficult to flush stools. Pancreatic enzyme replacement therapy, taking enzyme capsules with meals, is used to manage that.
Now on to pancreatic malignancy. Pancreatic cancer, which is sadly a very aggressive cancer, often caught late. What are the big risk factors and symptoms to watch for that might be signals?
Strong risk factors include being over 50, having a family history of pancreatic cancer, certainly cigarette smoking, having chronic pancreatitis itself, obesity, and diabetes. These all increase the risk.
And the symptoms.
The most common symptoms, which unfortunately often appear only when the disease is advanced, are significant unintentional weight loss, persistent abdominal or back pain, and jaundice, that yellowish tint to the skin and eyes, often from the tumor blocking the bile duct.
How is it usually diagnosed if suspected?
A contrast-enhanced CT scan of the abdomen is typically the first major imaging step. It's pretty good at finding tumors. If no mass is obvious on CT, but malignancy is still highly suspected, perhaps based on symptoms or other tests,
Then what?
then endoscopic ultrasound, or EUS, might be performed. That uses an endoscope with an ultrasound probe on the tip to get really close images from inside the stomach or duodenum right next to the pancreas. It's very sensitive for small tumors and allows for biopsies. Sometimes ERCP is also involved.
Okay, let's shift focus now to the small and large bowel, the intestines. This is where we can find issues like diarrhea, constipation, and inflammatory bowel disease. Starting with diarrhea, how do we distinguish between just a short bout and something chronic, and what about specific causes?
Right, so acute diarrhea is usually short-lived, maybe a few days. But for severe acute diarrhea, especially if there's fever or blood, stool studies are often indicated. We check for things like fecal leukocytes, which suggest inflammation, ova and parasites, bacterial cultures, and importantly, C. difficile toxin, especially if there's been recent antibiotic use.
And C. diff as treatment.
C. difficile infection, CDI, is typically treated with specific oral antibiotics like vancomycin or fidaxomicin. For really severe fulminant cases, IV metronidazole might be added.
Okay, now let's talk about celiac disease. This is one of those conditions with a truly surprising range of symptoms, isn't it? Both gut-related and things that seem completely unrelated.
You're absolutely right. Celiac disease definitely presents with classic GI symptoms like abdominal pain, diarrhea, bloating, maybe weight loss. But it often, and this is a big aha moment for many people, also has significant extraintestinal manifestations.
Like what?
Things like unexplained iron deficiency anemia is very common. A specific itchy, blistering skin rash called dermatitis herpetiformis, or even bone loss like osteopenia or osteoporosis because of poor calcium and vitamin D absorption. It's truly a systemic condition, not just a gut problem.
So given that wide range of potential symptoms, what's the diagnostic process for celiac? How do you pin it down?
Diagnosis usually starts with specific blood tests looking for antibodies, most commonly tissue transglutamase IgA antibodies or TTG IgA.
Okay.
But here's a key point. It's important to also check the person's total serum IgA levels at the same time because about 10% of people with celiac disease are actually IgA deficient, meaning they don't make IgA antibodies properly.
So the main test would be negative.
Exactly, a false negative. In those cases, you need to use different tests based on IgE antibodies. If the antibody tests are positive, the diagnosis is typically confirmed with a biopsy of the duodenum, the first part of the small intestine, taken during an upper endoscopy.
And what does the biopsy show?
It shows the characteristic damage. Flattened villi, those little finger-like projections that absorb nutrients and increase numbers of immune cells, intraepithelial lymphocytes within the lining.
And how is celiac disease managed long-term? Is it just about avoiding gluten? That sounds simple, but probably isn't easy.
Lifelong strict adherence to a gluten-free diet is absolutely crucial. There's no other treatment. And even tiny amounts of gluten can cause ongoing damage, even without obvious symptoms.
And other considerations.
Yes, because of the malabsorption, nutritional deficiencies are common. So screening for and treating low levels of iron, calcium, vitamin D, and folic acid is really important. Also, pneumococcal vaccination is often recommended because some studies suggest a potential increased risk of infection due to hyposplenism, kind of a sluggish spleen function.
Is there a serious complication to be aware of?
There is, though thankfully rare. It's called enteropathy-associated T-cell lymphoma, or EATL. It's an aggressive type of lymphoma that's seen primarily in celiac patients who haven't maintained good dietary control over many years. It highlights why sticking to the diet is so critical.
What about small intestinal bacterial overgrowth, or SIBO? That sounds like, well, a mouthful and potentially a messy problem.
Yeah, SIBO can definitely be a messy problem. The symptoms often overlap with other things: abdominal pain, persistent diarrhea, uncomfortable bloating, excessive flatulence, and signs of malabsorption. Sometimes it can even lead to macrocytic anemia because the bacteria interfere with vitamin B12 absorption.
Where does it typically happen?
It's more common after certain types of gastric surgery, like Roux-en-Y gastric bypass, which alters the anatomy, or in conditions with poor gut motility, like long-standing diabetes mellitus or systemic sclerosis, where things just don't move through the small bowel quickly enough, allowing bacteria to build up where they shouldn't be.
How do you diagnose SIBO?
Diagnosis is often made clinically, but tests can help. A common one is a hydrogen breath test, where you drink a sugar solution and then breathe into a device that measures gases like hydrogen and methane, which are produced by the overgrown bacteria fermenting the sugar. Or sometimes a direct sample of fluid from the jejunum, part of the small intestine, is taken during endoscopy to culture the bacteria.
And treatment.
Treatment involves targeted antibiotics to reduce the bacterial overgrowth. Rifaximin is a common choice because it's poorly absorbed and stays mainly in the gut. Often, addressing the underlying cause, if possible, is also important.
Lactose intolerance is pretty well known, but our sources mention it can also be a temporary issue, secondary to other gut problems, right?
That's absolutely correct. The classic symptoms are crampy abdominal pain, bloating, increased flatulence, and diarrhea after consuming lactose found in dairy products. But yes, it can definitely be a secondary problem.
How so?
Acute infections, like a bad case of viral gastroenteritis, can temporarily damage the brush border of the small intestine where the lactase enzyme is produced, so you might become temporarily lactose intolerant after a stomach bug. Similarly, chronic inflammation, like in Crohn's disease affecting the small bowel, can also lead to secondary lactose intolerance.
And sometimes, maybe rarely, people can cause their own diarrhea problems leading to something called factitious diarrhea. What's that about?
Yes, this is usually a diagnosis of exclusion, meaning other causes have been ruled out. It's typically due to the secret abuse of laxatives.
How would you know?
Stool analysis often shows a specific type of osmotic diarrhea with a particular osmolality pattern that suggests laxative use. And sometimes, if a colonoscopy is done, it might reveal melanosis coli, a dark pigmentation of the colon lining that's a telltale sign of chronic use of certain types of laxatives. It's a reminder that sometimes the root cause isn't a disease process itself.
Okay, let's talk about the opposite problem. Constipation. When does it cross the line from just a temporary inconvenience to being considered chronic?
Good question. Chronic constipation isn't just having a slow day now and then. It's typically defined by specific criteria, like having fewer than 3 bowel movements per week and straining during more than 25% of those movements for at least 3 months. It's a persistent, bothersome pattern.
And, like with other GI issues we've discussed, there are clear alarm features that signal a need for further evaluation, like a colonoscopy, rather than just reaching for over-the-counter remedies indefinitely.
Absolutely critical to know these. These include new onset constipation, especially in older adults, anemia, any visible blood in the stool, hematochezia, a positive fecal occult blood test, unexplained weight loss, a family history of colon cancer or IBD, or a prominent unexplained change in your usual bowel habits or stool caliber. These are signals your body is sending that something potentially more serious might be underlying the constipation.
So, assuming no alarm features, what's the initial management approach for chronic constipation?
It always starts with the basics. Dietary fiber aiming for 20-30 grams per day, increased fluid intake, and lifestyle changes like regular physical activity. These are foundational.
And if that's not enough?
If pharmacologic therapy is needed, bulk-forming laxatives like methylcellulose or psyllium are generally preferred first. They work by absorbing water and adding bulk to the stool. For opioid-induced constipation, which is a very common problem, specific laxatives like a combination of senna and Docusit or osmotic laxatives like polyethylene glycol are often initial steps.
What about more serious acute causes of bowel obstruction or pseudo-obstruction that can present with constipation or lack of bowel movements?
There are a couple of important ones. Acute colonic pseudo-obstruction, also known as Ogilvie syndrome, is a fascinating condition. The colon becomes massively dilated, looking like there's a blockage, but there's no actual mechanical obstruction.
What causes that?
It's often seen after surgery, particularly orthopedic or pelvic surgery, or in patients with severe illness, electrolyte imbalances, or certain medications that affect gut motility. It's diagnosed by X-ray or CT, showing the dilated colon without a transition point.
How's it managed?
Management is initially supportive bowel rest, IV fluids, treating underlying causes. If the colon doesn't decompress, or if the cecum, the start of the large bowel, gets dangerously large, over 10-12 centimeters, a medication called neostigmine can be given intravenously to stimulate colonic contraction. Sometimes colonoscopic decompression is needed.
And sigmoid volvulus. That sounds painful.
It is. That's an actual twisting of the sigmoid colon on itself, cutting off its blood supply and causing an obstruction. It's more common in elderly or institutionalized patients, often those with chronic constipation.
How does that look?
An abdominal X-ray often shows a characteristic finding. A huge air-filled loop of sigmoid colon, sometimes described as looking like a bent inner tube or a coffee bean. Uncomplicated cases where the bowel tissue is still viable are often treated initially by detorsion, untwisting it using a flexible sigmoidoscope or colonoscope. Surgery is usually needed later to prevent recurrence.
Next up, the inflammatory bowel diseases,
Mm.
Crohn's disease and ulcerative colitis. These are two distinct conditions that often get grouped together under the umbrella term IBD, but they're different beasts, aren't they?
They absolutely are different, although they do share some general characteristics, both often present in early adulthood, maybe teens to 30s, with symptoms like persistent abdominal pain, diarrhea, which can be bloody, especially in UC weight loss, fever, and fatigue.
And something else to consider.
Yes, it's important to remember that patients with IBD have a higher prevalence of Clostridium difficile colonization and infection. So if someone with known IBD has a flare-up, especially after antibiotics or hospitalization, C. diff needs to be considered and tested for, as it requires specific treatment on top of managing the IBD flare.
Okay, so what specifically distinguishes Crohn's from ulcerative colitis? This is a really key difference for people to understand.
This is probably the major aha moment for understanding IBD. Crohn's disease involves transmural inflammation. That means the inflammation goes through the entire thickness of the bowel wall, from the inner lining to the outer surface.
And location.
Crohn's can affect any part of the GI tract, literally from the mouth to the anus. And it often occurs in patches with areas of inflammation separated by normal-looking bowel tissue. These are called skip lesions.
And complications.
Because the inflammation is deep, transmural, Crohn's is more prone to complications like strictures, narrowing of the bowel, fistulas, abnormal tunnels connecting the bowel to other organs or the skin, and abscesses, collections of pus. For example, a rectovaginal fistula, a tunnel between the rectum and vagina, might be suspected if a woman reports passing stool or gas from the vagina.
So Crohn's, deep, anywhere, patchy, prone to tunnels and abscesses. Got it. What about ulcerative colitis, UC? How is that different?
Ulcerative colitis, or UC, involves inflammation that is generally limited to the mucosa, the innermost lining of the bowel wall. It's more superficial.
And location for UC?
UC almost always starts in the rectum and extends proximally up the colon in a continuous fashion. There are no skip lesions. It might affect just the rectum, proctitis, the left side of the colon, or the entire colon, pancreatitis. But it doesn't typically involve the small intestine, except sometimes for a little backwash ileitis right at the end.
And a major distinction regarding cure.
Yes, this is a critical point for prognosis and treatment decisions. Since UC only affects the colon and rectum, surgically removing the entire colon and rectum, a total proctocolectomy, is considered curative for the disease itself, though it obviously has major lifestyle implications. This is not the case for Crohn's, as it can recur even after surgery.
Any other key association with UC?
Patients with UC, particularly those with extensive colitis, have an increased risk of developing primary sclerosing cholangitis, or PSC, that inflammatory condition of the bile ducts we might discuss later.
And the management for these conditions. It sounds like it can be quite complex, involving different types of medications.
It is complex and tailored to the individual, the type of IBD, severity, and location. From mild to moderate UC, particularly if limited to the rectum or left colon, topical mesalamine, 5-ASA compounds, given as suppositories or enemas, is often first line. Oral 5-ASAs are used for more extensive or moderate disease.
What about flares?
Corticosteroids, like prednisone, are very effective for inducing remission during flares of both Crohn's and UC, but because of side effects, they are not suitable for long-term maintenance therapy.
And for more severe disease or maintenance?
For moderate to severe disease or patients who become steroid dependent, we move to immunosuppressants like azathioprine or 6-mercaptopurine, and increasingly biologic therapies, particularly the anti-TNF agents like infliximab or adalimumab, are used. These target specific inflammatory pathways.
Anything patients should avoid.
Yes, it's important to note that even common over-the-counter NSAIDs like ibuprofen can actually trigger IBD relapses or worsen inflammation, so they should generally be avoided.
And vaccinations for those on biologics.
Patients on anti-TNF therapy and other immunosuppressants should receive standard adult immunizations like the flu shot and pneumococcal vaccine, but they should strictly avoid live vaccines like the measles, mumps, rubella, MMR, or varicella chickenpox vaccine because their suppressed immune system can't handle the live virus.
Let's discuss mesenteric ischemia next. This sounds serious, like an intestinal heart attack, related to blood flow to the intestines. How does chronic differ from acute?
That's a good analogy. Chronic mesenteric ischemia is kind of like angina of the gut. It typically presents with what's called cytophobia, literally a fear of eating.
Why?
Because patients experience predictable, intermittent, dull abdominal pain, usually in the epigastric area, starting shortly after meals when the gut needs more blood flow for digestion, and it often resolves within an hour or two as digestion winds down. They learn to eat less to avoid the pain, leading to weight loss.
How's it diagnosed?
It's usually diagnosed by imaging that visualizes the blood vessels supplying the intestines, like CT angiography, CTA, or MR angiography, MRA, looking for significant narrowing or blockages in the main mesenteric arteries.
And acute mesenteric ischemia. That sounds like a much more sudden, severe event.
It is. This is a true vascular emergency. It's characterized by the rapid onset of severe abdominal pain, often centered around the umbilicus, belly button, that is classically described as being out of proportion to the physical examination findings. Meaning the patient is in excruciating pain, maybe writhing, but when the doctor examines their abdomen, it might not be very tender initially. This discrepancy is a huge red flag. Blood in the stool, hematochezia, is often a late finding, indicating bowel infarction, tissue death.
What causes the acute form?
It's frequently due to an embolus, a blood clot that travels from elsewhere, most commonly the heart, for example, in atrial fibrillation, lodging in a mesenteric artery. Or it can be due to a thrombus forming directly in a diseased artery, or sometimes non-occlusive ischemia from low blood flow states. Diagnosis is urgent, usually with CTA. Treatment often requires immediate surgery or endovascular intervention to restore blood flow.
What about ischemic colitis? Is that different?
Yes, ischemic colitis specifically involves the large bowel, the colon. It typically presents with a more abrupt onset of crampy abdominal pain, usually localized over the affected segment of colon, often the left side or watershed areas like the splenic flexure, followed within hours by the passage of bright red blood or bloody diarrhea.
What causes that?
It's usually due to a temporary reduction in blood flow to the colon, often triggered by systemic low flow states like dehydration, heart failure, strenuous exercise, or sometimes certain medications. It's particularly common in watershed areas of the colon where the blood supply is most tenuous. Colonoscopy confirms the diagnosis by showing characteristic inflammatory changes, ulcerations, or bluish discoloration consistent with ischemia. Management is usually supportive.
Now we're moving into the essential organs of digestion and detoxification, the liver and gallbladder. This can get pretty complex, so let's start with simply understanding abnormal liver tests, which many people might see on their routine blood work and get worried about.
Right, those liver function tests, or LFTs. When AST, aspartate aminotransferase, and ALT, alanine aminotransferase, are elevated, that pattern usually indicates hepatocellular injury, meaning damage directly to the liver cells themselves. Think of it like a bruise on the liver.
Okay, cell damage. What if it's other enzymes?
If alkaline phosphatase, or ALP, is elevated, especially along with another enzyme called GGT, gamma-glutamyl transferase, that pattern points more towards a biliary origin or cholestatic injury. It suggests a problem with the bile ducts or the flow of bile, either inside or outside the liver.
So what are some common reasons for these abnormal tests that might pop up on someone's labs, making them ask, what's wrong with my liver?
Oh, there are many common causes. Certainly non-alcoholic fatty liver disease is huge now. Medications are a big one. Lots of drugs can affect the liver. Viral hepatitis like B and C, alcoholic liver disease. Less common but important are things like hemochromatosis, where iron builds up, autoimmune hepatitis, where the immune system attacks the liver, and Wilson disease, a disorder of copper metabolism.
Anything surprising?
Interestingly, as we touched on earlier, even celiac disease can cause unexplained mild elevations in AST and ALT, so the gut-liver connection is strong.
Non-alcoholic fatty liver disease, or NAFLD, and its more severe form, NASH, seem to be increasingly common, almost reaching epidemic proportions in some areas.
They are indeed the most common cause of abnormal liver test results in the U.S. and many Western countries. NAFLD is simply characterized by fat accumulation in the liver, called hepatic steatosis. NASH, which stands for non-alcoholic steatohepatitis, is more serious. It includes not just fat, but also inflammation and often liver cell injury, sometimes with fibrosis or scarring.
What's driving this increase?
It's strongly associated with the features of metabolic syndrome, things like type 2 diabetes, obesity, especially central obesity, high triglycerides, and hypertension. The aha moment here for management is that addressing these underlying risk factors through diet, exercise, weight loss, controlling blood sugar, and lipids is the cornerstone of treatment.
Do you always need a biopsy?
While NAFLD can often be suspected based on imaging in labs, a liver biopsy is still generally considered the gold standard for definitively diagnosing SH and, importantly, for staging the degree of fibrosis or scarring, which is the main predictor of long-term outcomes like cirrhosis.
Let's touch on viral hepatitis, specifically B and C, and their screening. Many people might not even know they're at risk or infected.
That's true, especially for hepatitis C, which can be silent for decades. That's why a one-time screening for hepatitis C virus, HCV infection, is recommended for all adults aged 18 and older at least once in their lifetime. Additionally, screening is recommended for specific groups like individuals born between 1945 and 1965, the baby boomer cohort, and for anyone with increased risk factors like past or present injection drug use or having received blood transfusions before 1992 when screening became widespread.
And for hepatitis B, HBV.
Screening for HBV is recommended for people from regions where it's endemic, people with HIV, injection drug users, men who have sex with men, and household contacts or sexual partners of infected individuals, among others. Most acute adult HBV infections resolve spontaneously, but chronic infection can develop.
Does chronic HBV always need treatment?
Not necessarily. A surprising fact for some is that many people are chronic inactive carriers. They have the virus, but their liver tests, ALT, are normal, and the amount of virus in their blood, HBV DNA, is low. These individuals typically don't require antiviral treatment, but, and this is key, surveillance for hepatocellular carcinoma, HCC, liver cancer is still indicated, usually with liver ultrasounds every 6 months, because the risk remains elevated even in the inactive state. Treatment is recommended for active chronic infection, elevated ALT and high HBV DNA, cirrhosis, acute liver failure, or during immunosuppressive therapy to prevent reactivation.
What about hepatitis C once it's diagnosed? A positive antibody test isn't the end of the story, right?
Correct. A positive HCV antibody test just means you've been exposed at some point. It needs confirmation with an HCV RNA test, which detects the actual virus genetic material and tells us if the infection is currently active.
And the treatment outlook.
The truly great news here, representing a massive advance in medicine over the last decade, is that highly effective, well-tolerated, all-oral, direct-acting antiviral DAA treatments are now available. These regimens, usually taken for 8-12 weeks, can cure over 95% of HCV infections. Curing HCV can prevent or delay the development of cirrhosis and liver cancer, significantly improving long-term health. It's a game changer.
Autoimmune hepatitis, or AH.
Yeah.
The name suggests the body attacking itself. What does that look like?
It does often present with nonspecific symptoms like fatigue, nausea, maybe some small joint aches, or arthralgias. And it can sometimes be associated with other autoimmune diseases like thyroiditis or rheumatoid arthritis. Diagnosis involves finding elevated transaminases, a STALT, often very high levels of immunoglobulins in the blood, hypergammaglobulinemia, and positive serologic markers like ANA, anti-nuclear antibody, or ASMA, anti-smooth muscle antibody.
And confirmation.
A liver biopsy is usually needed to confirm the diagnosis and typically shows characteristic features like interface hepatitis or piecemeal necrosis. Treatment involves immunosuppression, usually starting with glucocorticoids, like prednisone, often combined with azathioprine for long-term management.
Here's where liver disease gets really serious and potentially life-threatening. Cirrhosis and its major complications. This represents advanced scarring of the liver.
It does. Cirrhosis is essentially the end stage of many chronic liver diseases, where scar tissue replaces healthy liver tissue, disrupting its structure and function. Ascites, which is the accumulation of fluid in the abdominal cavity, is the most common complication.
How do you know the fluid is from cirrhosis?
A diagnostic paracentesis, drawing off some fluid with a needle, is performed. Calculating the serum to ascites albumin gradient, or SAG, is key. A SAG of 1.1 GDL or higher indicates that the ascites is due to portal hypertension, high pressure in the liver's blood supply, which is typically caused by cirrhosis or sometimes severe heart failure.
How is ascites managed?
Management involves strict sodium restriction in the diet, usually less than 2 grams per day, and diuretics, typically a combination of spironolactone and furosemide. For large volume or symptomatic ascites, therapeutic paracentesis, draining large amounts of fluid, provides relief.
And esophageal varices sound terrifying, enlarged veins in the esophagus that can rupture and bleed massively.
They are a very serious complication, yes. These swollen veins develop as collateral pathways because the high pressure in the liver, portal hypertension, forces blood to find alternative routes back to the heart. A screening upper endoscopy is recommended at the time of cirrhosis diagnosis to detect varices before they bleed.
What if they do bleed?
Acute variceal hemorrhage is a medical emergency. Immediate management is critical. Aggressive fluid resuscitation, but avoiding overtransfusion, medications like intravenous octreotide to reduce portal pressure, prophylactic antibiotics, as infection often triggers or complicates bleeding, and urgent endoscopic therapy, usually band ligation, where tiny rubber bands are placed around the varices to stop bleeding. After a bleed, beta blockers, like propranolol or nadolol, are used for secondary prophylaxis to prevent recurrence.
What about hepatic encephalopathy, HEHE? That sounds like it affects the brain.
It does. It's a spectrum of neuropsychiatric dysfunction caused by the failing liver's inability to clear toxins, primarily ammonia, from the bloodstream. These toxins then reach the brain and interfere with its function. Symptoms can range from subtle changes in personality or sleep patterns to confusion, lethargy, asterixis, a flapping tremor of the hands, and even coma.
What triggers episodes of HEE?
Episodes are often precipitated by specific factors like gastrointestinal bleeding, which increases ammonia production from blood in the gut, infections, especially spontaneous bacterial peritonitis, an infection of the acidic fluid, electrolyte disturbances, constipation, or even consuming too much dietary protein.
How is HEE treated?
First-line treatment is lactulose, a non-absorbable sugar that works in the colon to reduce ammonia production and absorption. It's typically titrated to produce 2 to 3 soft bowel movements per day. For patients with recurrent episodes despite lactulose, the antibiotic rifaximin is often added. It helps by further reducing ammonia-producing bacteria in the gut.
And a major long-term concern in cirrhosis is the development of hepatocellular carcinoma, HCC, primary liver cancer.
Absolutely. About 80% of HCC cases worldwide occur in patients with underlying chronic liver disease, particularly cirrhosis from any cause or chronic hepatitis B infection even without cirrhosis. This is why surveillance is so important.
What does surveillance involve?
Routine surveillance with a liver ultrasound, usually every 6 months, is recommended for virtually all patients with cirrhosis and some high-risk chronic HBV patients without cirrhosis to detect HCC at an early, potentially curable stage. Diagnosis can often be made non-invasively, without a biopsy, based on characteristic enhancement patterns seen on specialized imaging like 4-phase contrast-enhanced CT or MRI.
Briefly, what's Budd-Chiari syndrome? Sounds dramatic.
Budd-Chiari syndrome is relatively rare but serious. It's caused by obstruction of the hepatic venous outflow, the veins draining blood out of the liver. This leads to massive liver congestion. It typically presents acutely with severe right upper quadrant pain, rapid onset of hepatomegaly, enlarged liver, jaundice, and ascites. The SAG value will be high, 1.1, indicating portal hypertension due to the outflow obstruction. It's often related to underlying clotting disorders.
Also, Wilson disease, that genetic copper issue, sounds quite distinctive because it affects more than just the liver hitting the brain, too.
It is distinctive. It's an inherited defect in copper transport, leading to copper accumulation in various organs, primarily the liver, brain, and eyes. We suspect it particularly in younger patients, usually under 40, presenting with unexplained liver disease, ranging from elevated enzymes to acute liver failure or cirrhosis, especially if they also have neurological or psychiatric symptoms.
Like what kind of symptoms?
Neurologic symptoms can include tremor, dysarthria, slurred speech, coordination problems, ataxia, Parkinsonism, or dystonia. Psychiatric issues like depression, personality changes, or psychosis can also occur. A classic, though not always present, physical sign are Kaiser-Fleischer rings greenish-brown copper deposits in the cornea of the eyes, best seen on a slit lamp exam.
Diagnosis.
Diagnosis involves tests like low serum ceruloplasmin, the main copper-carrying protein, usually low, elevated 24-hour urine copper excretion, and sometimes liver biopsy showing high copper content. Wilson disease can also cause Coombs negative hemolytic anemia, red blood cell breakdown. Early diagnosis and treatment with copper chelating agents are crucial.
What about primary biliary cholangitis, or PBC? Who gets that?
PBC is a chronic progressive autoimmune disease that primarily targets the small bile ducts within the liver. It predominantly affects middle-aged women, about a 9.1 female-to-male ratio. It often begins insidiously with symptoms like profound fatigue and pruritus, itching, which can be quite severe.
What do the liver tests show?
The characteristic liver enzyme pattern is cholestatic, a markedly elevated alkaline phosphatase, ALP, with lesser elevations in ASTALT. The hallmark diagnostic marker is the presence of anti-mitochondrial antibodies, AMA, in the blood, found in about 95% of patients. A liver biopsy can confirm the diagnosis, but isn't always necessary if the clinical picture and AMA are typical.
Is there treatment?
Yes, ursodeoxycholic acid, UDCA, is the mainstay of treatment. It doesn't cure PBC, but it significantly slows disease progression, improves liver biochemistry, and delays the need for liver transplantation in many patients.
The primary sclerosing cholangitis, PSC. How is that different from PBC?
PSC is also a chronic cholestatic liver disease, but it affects the larger bile ducts both inside and outside the liver, causing inflammation, fibrosis, and stricturing narrowing. A key distinction is its strong association with inflammatory bowel disease. About 70–80% of patients with PSC also have underlying ulcerative colitis.
How does it present?
Like PBC, it often presents with fatigue, itching, and a cholestatic liver enzyme pattern. The diagnosis is usually made by imaging the bile ducts, typically with magnetic resonance cholangiopancreatography, MRCP, or sometimes ERCP. These show the characteristic multifocal stricturing and dilation of the bile ducts, giving them a beaded appearance.
Treatment for PSC.
Unfortunately, unlike PBC, there is no proven effective medical therapy that halts the progression of PSC. UDCA has not shown a clear benefit. Management focuses on monitoring for complications, managing symptoms like itching, and sometimes endoscopic therapy, like dilation or stenting, for dominant bile duct strictures. Patients with PSC are at significantly increased risk for cholangiocarcinoma, bile duct cancer, and if they also have UC, colorectal cancer, so surveillance for these malignancies is critical. Liver transplant is the only definitive treatment for end-stage PSC.
Let's move on to the gallbladder and bile ducts nearby. Gallstones are incredibly common, but most people don't even know they have them unless they cause symptoms, right?
That's absolutely right. The vast majority, maybe 60–80% of gallstones are asymptomatic, discovered incidentally on an ultrasound done for other reasons. And generally, asymptomatic gallstones don't require treatment. They're just there.
So when do gallstones become a problem that needs attention, moving from being silent passengers to causing symptoms?
They become symptomatic primarily in two ways. First is biliary colic. This is episodic, often severe pain, usually in the right upper quadrant, RUQ, or epigastrium, often radiating to the back or shoulder blade. It typically occurs after eating, especially fatty foods, as the gallbladder contracts against a stone, temporarily blocking its exit. The pain usually lasts from 30 minutes to a few hours and then resolves completely.
And the second way?
The second is acute cholecystitis. This happens when a stone becomes impacted in the cystic duct, the gallbladder's exit tube, causing sustained obstruction, inflammation, and infection of the gallbladder wall. This results in more prolonged RUQ pain lasting 4 to 6 hours, often accompanied by fever, nausea, vomiting, and specific signs on examination, like Murphy's sign, and leukocytosis, high white blood cell count, on blood work.
What's the treatment for symptomatic stones?
For both recurrent biliary colic and acute cholecystitis, the definitive treatment is surgical removal of the gallbladder, a cholecystectomy, which is most commonly done laparoscopically, minimally invasive surgery. For acute cholecystitis, surgery is usually recommended during the same hospital admission.
What about gallbladder polyps? Are those like colon polyps? Do they need attention even if they're not causing pain like stones?
That's a great question. Gallbladder polyps are growths on the inner wall. While most are benign, some have malignant potential. The size is the key factor. This is a key aha for malignancy risk. Polyps larger than 1 centimeter, 10 millimeter, are generally recommended for cholecystectomy, even if they are asymptomatic, because of the increased risk of harboring or developing gallbladder cancer. Smaller polyps may be monitored with ultrasound.
And what happens if a gallstone escapes the gallbladder and gets into the main common bile duct? It's choledocholithesis, right?
Exactly. Choledocholithesis is a stone in the common bile duct. This can cause biliary-type pain, similar to colic, but it might also lead to jaundice if the stone obstructs bile flow significantly, elevations in liver enzymes, especially ALP and bilirubin, and importantly, dilated bile ducts seen on ultrasound or other imaging.
How are those stones removed?
ERCP, endoscopic retrograde cholangiopancreatography, is the primary tool for both diagnosing and removing common bile duct stones. An endoscope is passed down to the duodenum, a catheter is inserted into the bile duct opening, dye is injected to visualize the stones, and then instruments can be passed through the scope to extract the stones, often after widening the opening, sphincterotomy. ERCP is especially indicated if the choledocholithesis is complicated by cholangitis or gallstone pancreatitis.
What if there's an actual infection within the obstructed bile duct's cholangitis? That sounds like a really serious situation.
It is. Acute cholangitis is a potentially life-threatening infection within the biliary tree, usually caused by bacterial contamination proximal to an obstruction, most commonly a gallstone. The classic, though not always present, presentation is Charcot's triad, fever, right upper quadrant pain, and jaundice. Sometimes it progresses to Reynolds pentad, adding altered mental status and shock.
Management.
This requires immediate medical attention. Patients need broad-spectrum intravenous antibiotics right away. And critically, biliary drainage is necessary to relieve the obstruction and control the infection. If the patient doesn't improve rapidly with antibiotics alone, urgent biliary drainage via ERCP to remove the stone and drain pus is absolutely necessary, usually within 24-48 hours. It can quickly progress to sepsis if not treated promptly.
Okay, we've navigated through the specifics of many conditions affecting different parts of the GI tract. Let's shift now to an overarching and incredibly important topic: essential screenings and how we identify the source of gastrointestinal bleeding, which can be very alarming for anyone experiencing it.
Yes, this is where proactive health measures and knowing what to look for and what doctors do really come into play. First, just recognizing GI bleeding. Upper GI bleeding from the esophagus, stomach, or duodenum often presents as hematemesis, vomiting blood, which might look bright red or like coffee grounds if it's been sitting in stomach acid, or melena, which are those black, tarry, foul-smelling stools caused by digested blood.
And lower GI bleeding.
Lower GI bleeding from the colon or rectum typically presents as hematochezia, the passage of bright red blood per rectum, which might be mixed with stool streaked on the surface or just frank blood. The color often gives you a clue about how high up or low down the bleeding source is and how fast it's bleeding.
So if bleeding occurs, regardless of the suspected source, what are the absolute initial steps in management?
The first priorities are always assessment of hemodynamic stability, checking blood pressure, heart rate, and rapid fluid resuscitation with intravenous fluids like normal saline or lactated ringers to restore volume if needed. Blood transfusions might be necessary depending on the amount of blood loss and the patient's clinical condition.
Is there a specific hemoglobin target for transfusion?
Generally, for most patients, the goal is to transfuse packed red blood cells to maintain a hemoglobin level around 7 GDL. However, a higher threshold, maybe greater than 9 GDL, might be used for patients with unstable coronary artery disease or active symptoms of cardiac ischemia. It's individualized.
Okay, resuscitation first. Then how do we diagnose and manage upper GI bleeding specifically, which can feel very urgent?
The most common causes of significant upper GI bleeding are peptic ulcer disease, PUD, those esophageal or gastric varices we discussed in the context of cirrhosis, erosive esophagitis or gastritis, and Mallory-Weiss tears.
And the key diagnostic step.
An urgent upper endoscopy, EGD, is crucial. It should ideally be performed within 24 hours of presentation for most patients, or even sooner within 12 hours for those with suspected variceal bleeding or severe ongoing hemorrhage. The endoscopy allows visualization of the source and, importantly, therapeutic intervention if needed.
What kind of intervention?
For high-risk ulcers identified during endoscopy, those with active bleeding, a non-bleeding visible vessel, or an adherent clot endoscopic therapy is performed. This might involve injecting epinephrine, applying thermal coagulation, cautery, or deploying clips to stop the bleeding. After endoscopic therapy for high-risk ulcers, patients are typically given high-dose intravenous PPI therapy for 72 hours to reduce the risk of rebleeding. And of course, any offending agents like NSAIDs or aspirin should be stopped, possible.
What about lower GI bleeding, often seen as bright red blood? What are the usual suspects there?
The most common causes of significant lower GI bleeding in adults are colonic diverticulosis, bleeding from diverticula, those small pouches in the colon wall, colitis, inflammatory, infectious, or ischemic, hemorrhoids, though usually less severe bleeding, angiodysplasia, abnormal blood vessels, and sometimes colon cancer or post-polypectomy bleeding.
And the workup.
Colonoscopy is typically the diagnostic procedure of choice for evaluating lower GI bleeding, although the timing depends on the severity of bleeding and patient stability. It allows visualization of the entire colon to identify the source and potentially treat it endoscopically. Example, clipping bleeding diverticula or angiodysplasia. Sometimes, if bleeding is very brisk, other tests like tagged red blood cell scans or CT angiography might be used first to help localize the bleeding site before attempting colonoscopy or angiography.
And sometimes, frustratingly, the source of bleeding isn't immediately obvious, even after both an upper endoscopy and a colonoscopy. What happens then?
That's referred to as obscure GI bleeding, where the source remains unidentified after initial endoscopic evaluation. This often implies a source in the small bowel, which is harder to reach.
What's common in the small bowel?
Angiodysplasia, also called arteriovenous malformations or AVMs, those small abnormal clusters of blood vessels are the most common cause of obscure GI bleeding, especially in older adults.
How do you find those?
Capsule endoscopy is often the first-line test for evaluating the small bowel in cases of obscure GI bleeding, particularly if the bleeding is overt, visible but slow, or occult, causing iron deficiency anemia. The patient swallows a small capsule containing a camera that takes thousands of pictures as it travels through the small intestine. If active, significant bleeding is suspected, sometimes deep enteroscopy using longer scopes or angiography might be considered.
Let's transition now to what might be the most critical screening discussion for many adults. Colorectal cancer, CRC. Our sources state it's shockingly the second most common cause of cancer and cancer-related mortality in the United States. That's huge.
Word. It is huge, but the good news is that it's also one of the most preventable cancers through screening, and there are identifiable risk factors. What's truly fascinating here, and a major aha for prevention, is that many risk factors are modifiable things related to lifestyle.
Like what?
These include factors like a diet high in fat and red or processed meats, a diet low in fiber, cigarette smoking, excessive alcohol consumption, obesity, especially abdominal obesity, and low levels of physical activity. Making positive changes in these areas can genuinely impact your risk.
Okay, so for someone at average risk, meaning no personal history of CRC or polyps, no IBD, no significant family history, what's the standard screening strategy recommended to look for this preventively?
There are several recommended options for average risk screening, which typically starts at age 45 now for most guidelines. Colonoscopy every 10 years is often considered the gold standard because it can both detect polyps and remove them in the same procedure, potentially preventing cancer from developing.
What are the alternatives to colonoscopy?
Alternate strategies include stool-based tests like the highly sensitive fecal immunochemical test, FIT, which checks for microscopic blood in the stool and should be done yearly if chosen. Another option is a multi-target stool DNA test, like Cologuard, which looks for both blood and specific altered DNA markers shed from polyps or cancer, typically done every 3 years. Or imaging options like CT colonography, virtual colonoscopy every 5 years are also available. The best test is the one that gets done.
But screening gets more personalized, often starting earlier and done more frequently if you're at increased risk. What about family history? How does that specifically change the recommendations?
Family history is a major risk factor. If you have one first-degree relative that's a parent, sibling, or child diagnosed with colorectal cancer or an advanced adenoma before age 60, or if you have 2 or more first-degree relatives diagnosed at any age,
Then what?
then screening colonoscopy should begin significantly earlier. The usual recommendation is to start at age 40, or 10 years younger than the age at which the youngest affected relative was diagnosed, whichever comes first. And importantly, the interval for repeat colonoscopy is typically shortened to every 5 years. It's about being much more vigilant.
For patients with inflammatory bowel disease, like the Crohn's and ulcerative colitis we discussed earlier, what's the surveillance approach, given their known increased risk due to chronic inflammation?
Right. The chronic inflammation itself increases the risk of developing dysplasia, precancerous changes, and CRC. For patients with extensive ulcerative colitis involving more than just the rectum, or Crohn's disease involving a significant portion of the colon, at least 1/3,
When did they start surveillance?
they should begin surveillance colonoscopy 8 to 10 years after the initial diagnosis of IBD was made. If the UC is limited to just the left side of the colon, surveillance might start a bit later, maybe 12-15 years after diagnosis.
And how often?
After the initial surveillance colonoscopy, repeat exams are typically recommended every 1 to 3 years, depending on the findings and individual risk factors. These surveillance colonoscopies often involve taking multiple biopsies throughout the colon to look for microscopic dysplasia, even in areas that look normal.
Now, what if you've already had polyps removed during a previous colonoscopy? How does that history impact the timing of your next screening? This seems really common.
It's very common, and the recommended surveillance interval depends heavily on the number, size, and type histology of the polyps found, as some carry a higher risk of future cancer than others.
Can you give some examples?
Sure. If you only had 1 or 2 small, less than 1 centimeter tubular adenomas, which are low risk, a repeat colonoscopy in 5 to 10 years might be reasonable. Guidelines vary slightly, often 5-7 years in practice. However, if you had 3 to 10 adenomas or any adenoma larger than 1 centimeter, or an adenoma with specific higher risk features like villus histology or high-grade dysplasia,
And sooner.
yes, then the recommendation is typically to repeat the colonoscopy in 3 years. If you had more than 10 adenomas found on a single exam, that raises suspicion for an underlying genetic predisposition, a familial polyposis syndrome. And repeat colonoscopy should be considered much sooner, perhaps within 1 to 2 years, along with potential genetic counseling.
What about very large polyps?
If a large polyp, greater than 2 centimeters, particularly a sessile, flat one, was removed piecemeal in multiple pieces, or if a polyp contained invasive adenocarcinoma but was completely removed endoscopically, a shorter interval follow-up colonoscopy, often within 2 to 6 months, is usually needed to ensure complete removal and check the site.
Lastly, let's touch on specific hereditary syndromes, which significantly increase the risk for colorectal cancer, often at a young age, and frequently involve risks for other cancers too.
Yeah.
These need very different surveillance.
Absolutely. These inherited conditions require highly specialized and intensive surveillance protocols. For example, familial adenomatous polyposis, or FAP, causes hundreds or even thousands of adenomatous polyps throughout the colon starting in adolescence, with nearly a 100% risk of CRC if the colon isn't removed.
So screening starts super early.
Yes, screening for FAP typically begins with annual flexible sigmoidoscopy starting at age 10 to 12. Patients with FAP also require regular upper endoscopy surveillance starting in young adulthood because they have a high risk of duodenal and periampullary cancers as well.
What about Lynch syndrome?
Lynch syndrome, also known as hereditary non-polyposis colorectal cancer, HNPCC, is the most common hereditary CRC syndrome. It doesn't cause thousands of polyps like FAP, but significantly accelerates the development of CRC and also increases the risk of other cancers, notably endometrial, ovarian, stomach, small bowel, urinary tract, and others. For Lynch syndrome, colonoscopy is recommended every 1 to 2 years, usually beginning between ages 20 to 25 or 10 years younger than the earliest CRC diagnosis in the family, whichever is earlier. Screening for other associated cancers, like endometrial, is also crucial.
Any others to briefly mention?
Peutz-Jeghers syndrome is characterized by multiple hamartomatous polyps throughout the GI tract and distinctive pigmented spots, mucocutaneous papules, around the mouth, nostrils, and eyes. It carries increased risks for various GI and non-GI malignancies. Colonoscopy surveillance usually starts around age 18. Serrated polyposis syndrome involves multiple serrated polyps, a different type, throughout the colon and also confers an increased CRC risk, warranting annual colonoscopy. The key message for all these syndromes is the need for very early, very frequent, and often multi-organ surveillance guided by genetic counseling and specialists.
And finally, after someone has actually had colorectal cancer and undergone curative surgical resection, what's the recommended follow-up screening with colonoscopy?
After curative surgery for CRC, the first postoperative colonoscopy should generally be performed within 1 year of the resection. This is to check for any missed synchronous cancers or polyps and to examine the surgical anastomosis site. If that 1 year colonoscopy is normal, the next one is typically recommended 3 years later, and if that's normal, then every 5 years thereafter, assuming no new findings. This structured follow-up helps detect any metachronous new cancers or polyps early.
Wow. We have covered a tremendous amount of ground today, really diving deep into everything from, the nuances of swallowing disorders and that vague stomach discomfort, right down to the critical importance of liver health, bowel regulation, and especially these timely and potentially life-saving cancer screenings.
It's a lot, but the key takeaway, I think, is that your digestive system, while incredibly resilient most of the time, also sends some pretty clear signals when something needs attention. Understanding these signals, rather than ignoring them or just hoping they go away, is really empowering.
Knowing when to seek professional advice, having some idea of the common diagnostic paths like we discussed, and actively engaging in the appropriate screenings based on your age and risk factors. These are all really powerful steps you can take.
Absolutely. Early awareness and action, guided by good information like hopefully we've provided today, can truly make all the difference in your long-term health and well-being. It's about being proactive.
So to leave you with a provocative thought as we wrap up, just think about how much of your daily life, your energy levels, your mood, maybe even your focus, and certainly your long-term health trajectory is influenced by the unseen, continuous, and incredibly complex work happening constantly within your gut.
It really is your inner engine room, working away 24/7.
So maybe consider this. What's one small change you could potentially make, or perhaps one question you might bring up with your doctor at your next visit to better support this vital inner world? What's one proactive step you could take towards your overall digestive well-being starting today?